Good evening, everyone.
Yeah. Well, I start sharing my slides and then, yeah. Hello, good evening, everyone. Welcome to this webinar, Carbetocin in Action by Hetero. Hetero Healthcare, as you know, we have 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV APIs in the world. We also have Asia's largest API manufacturing facilities at Visakhapatnam. At Heat Pro Doctors, we are 360 degrees solution provider. We strive to fulfill unmet healthcare needs. We reach to customers across India. We have a wide product range encompassing multiple specialties, including orthopedics, pulmonology, gynecology, dermatology, etc. We pioneer in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. We have recently introduced Carbetocin. Carbetocin, as you all know, is used for prophylactic management of PPH. And PPH is always best to be studied in textbooks rather than a patient being seen for PPH. And although there are a lot of guidelines and recommendations of PPH, we would always like to have our own doctor's insights into PPH and management by Carbetocin. For that, today we have got Dr. Alka Singla with us to present her experience. Welcome, madam. Dr. Alka
Thanks, sir.
Singla is MD, DNB, MN, AMS, Diploma in ART, IFS. Madam is Director, Department of Gynecology, Obstetrics and Infertility, Meher Special Super Specialty Hospital, Zirakpur. Madam is keen academician and has attended various conferences and presented papers in national conferences. Dr. Singla is published as author in Journal of Midlife Health, continuously learning and evolving, and special area of interest is female fertility, infertility, and infertility preservation. Welcome, Dr. Alka, and we wait for your experience on Carbetocin. I'll share the slides, madam. Wherever you want me to go fast, you can tell me.
Right, sir. Good evening, sir, and thank you for the nice introduction. And firstly, we'll have a smaller discussion on the postpartum hemorrhage. As you very rightly said, it should be in the books only. It's actually a nightmare for the gynecologist. We don't want to even think about this thing. Next slide, sir. Yes, I will go through fast in these slides. Postpartum hemorrhage is commonly known as PPH in our general language. And in the normal vaginal delivery, we say if the blood loss is more than 500 ml or in a cesarean section, more than 1000 ml of the blood loss, it is labeled to be as PPH, which is postpartum hemorrhage. We anticipate PPH in few cases, and sometimes it occurs when we are not expecting it at all. And we are discussing it today because it is a leading cause of maternal mortality in low resource countries, in low income countries, like we talk about India. Next slide. So if we go through the data, we just come to know that MMR in developing countries was 240 earlier and 16 in developed countries. And the high MMR ratio in developing countries and the most important contributing factor is the PPH. And so we are discussing how to lower this incidence of PPH. So 4Ts are commonly known for the etiology of the postpartum hemorrhage. It is tone, which is basically atonic uterus, in which uterine muscle is not able to contract, due to which the blood vessels keep on pouring blood like anything. And the next common things are coagulation disorders, or it may be the traumatic uterus, or it may be some retained tissue inside which doesn't let the uterus to contract properly. So clinical finding in PPH is basically patient will have the lower BP and high pulse, and we'll see that patient is going down. And I think that is sufficient. So next slide. So if we if we want to diagnose the PPH, we especially say that after the delivery, how much uneventful it might be. We have to look for pulse 1 minute complete in postpartum patient, along with the per abdomen examination, in which we want to say that uterus is very well retracted, along with the amount of blood loss, by giving a fresh pad to patient and checking it every hourly or 2 hourly, depending upon the risk status of the patient. So if the we see in any of thing that the pulse is rising or the BP is falling or uterus is flabby, we don't get a well retracted uterus. It and or the excessive blood loss is there. It means we are tackling a case of PPH. So approach towards is basically you just have to call for help, and I think we can move on next, sir, to this. Yes. So till now we have discussed that PPH is a something that we gynecologists just don't want to even dream about the thing. We say it is a nightmare. So to reduce the incidence of the maternal mortality, we need to lower the incidence of PPH, which is the most common cause of maternal mortality in low resource countries like India. So when we talk of the PPH, we say that atonic PPH is the most common reason for the postpartum hemorrhage. Atony means uterus muscle is not able to contract. For this, from the time being, if we say that one drug which is has been approved by WHO was oxytocin. Oxytocin was the drug of choice for the management, active management, or for the prophylaxis of the postpartum hemorrhage. The only problem with oxytocin was that it was not heat stable. So, in low resource countries where we are talking that PPH is very high, maternal mortality is very high, the problem is logistics and the cold chain maintenance which the oxytocin required. So that's why it always like that how to reduce the incidence of PPH even with the availability of the oxytocin. The only conclusion was that we have to look for some heat stable form of the oxytocin, and this was the rationale for the development of a new molecule which is a synthetic peptide analog of the oxytocin, but it is heat stable. That's why it has a shelf life of 24 months at 30 degrees Celsius, and it doesn't need cold chain storage, and thus lesser logistics are required. It is provided in a vial, very stable at room temperature, providing us a benefit in the low resource, less developing countries like India, where due to the poor quality of the oxytocin, we were not able to get the results we wanted to always have. And if we say that what are the molecules, we already discussed oxytocin, and oxytocin used to be the first choice. Now we are taking of the consideration of the carbetocin, which is now actually replacing the oxytocin because of its heat stable nature. And the rest of the thing which we'll discuss in the upcoming slides. The others are the ergometrin or the symptometrin or the misoprostol, which are comparatively lesser used these days. So basically, I already told you that the carbetocin, it is a next generation drug for the management of PPH, and it is a synthetic, long acting analog of oxytocin. And for the yes, sir, it is basically for the prevention of the postpartum hemorrhage. I am saying it again and again that it is basically approved for the prevention of the postpartum hemorrhage.
Correct.
So basically, WHO champion trial was started, and had a long number of just patients for the study, and the major result was that the carbetocin was found to be non-inferior to oxytocin in blood loss of 500 ml or more in a post-delivery patient, and need for the other uprotonics along with oxytocin. It was found to be non-inferior. So going fastly of these things, that blood loss of more than 500 ml, the efficacy for the carbetocin was found to be 14.5 and oxytocin was 14.4, which the relative risk and the confidence interval came out to be lesser than this thing, for which the non-inferiority of the carbetocin over oxytocin was established. And the similar thing was for blood loss of more than 1000 ml. Basically, it was found that it is non-inferior to oxytocin for the prevention of the blood loss of at least 500 ml or the use of additional utrotonic agents. Cochrane review was laid involving the 2635 women, in which it was found that carbetocin resulted in statistically significant reduction in the need for therapeutic utrotonics as compared to that of oxytocin, and it is also associated with the lesser blood loss when compared to the other utrotonics like symptometrin in the prevention of the PPH who have got vaginal deliveries. So coming to the guidelines, we get to know that WHO 2018 approved for the prophylaxis of the PPH carbetocin, equally good as that of oxytocin. And SOGC Canada 2009, they told us that the dose of the carbetocin is 100 microgram single dose in the form of IV bolus. Figo, Germany, FCOG, now all are saying that carbetocin is non-inferior to oxytocin for the prevention of PPH. So now I would like to tell you my experience with carbetocin. I am in using carbetocin for last might be 8-9 months or maybe more, and I am really satisfied with the results that carbetocin is giving. So firstly, I'm telling you my patient. She was Mrs. X, G2P1L1. She came to me at 39 weeks of period of gestation. Uh, she previously she had a normal delivery and her age was 31 years female, and the previous there was history of postpartum hemorrhage during the previous vaginal delivery. It was done somewhere outside, but patient gave history that it was blood loss was that much that blood 1 unit of PRBC had to be transfused at that time. So when we take the patients that who are at high risk of PPH, we always say that if there is a previous history of PPH, there are always more chances to have PPH, especially when we are conducting a second delivery and the second delivery after 5 or 6 years of gap. So in view of this anticipated high risk of PPH, I gave 1 dose of injection carbetocin, slow IV, 100 microgram bolus over 1 minute as prescribed, and it was found that there was no PPH, no blood transfusion was required. Actually, the patient's HB didn't fall, and we were able to discharge the patient the next very day. So now I will tell you about my experience in a cesarean section patient. She was a primary gravida. She came to me at 38 week 3 days period of gestation, and she was a case of essential hypertension. She was on tablet labetalol 100 mg thrice a daily for matlab, since 8th week of conception. Due to the uncontrolled BP and the lesser fetal movements, induction of labor was planned for the patient. And I haven't mentioned, but the cervical findings were good. At per vaginum, cervix was around 2 finger loose, for which the induction was planned with the injection oxytocin. However, due to the non-progress of labor, decision for emergency LSCS was taken. So in this high-risk patient, especially with hypertension, as a prophylactic measure, I used carbetocin immediately after the delivery of the baby. And luckily, or I would say that as always mentioned, that carbetocin is a better drug. So there no PPH was seen, and BP was controlled post-operatively and also the carbetocin had got no negative effect on the high BP of the patient, and we were able to discharge the patient after 48 hours of the surgery. So now there is one more patient. She was second gravida A1 at age of 33 years. She was a case of gestational diabetes mellitus. She was on metformin, 500 mg twice a day. It was twin pregnancy, IVF conception. She came to me at 34-week 5 days period of gestation in labor, and as per the ultrasound findings, first baby was breech. After looking at all the things, the decision for emergency cesarean for the patient was taken, and after explaining all the high risk and anticipating due to the polyhydramnios, twin pregnancy, IVF conception, GDM, the risk it was a high risk pregnancy in which we were expecting a lot of PPH. So again, as a prophylactic measure against the possibility of the PPH, we gave single dose of carbetocin, 100 microgram IV bolus immediately after the delivery of twins, and there was no PPH which was probable in this high risk case.
Right, madam. Thank you so much for your insights. It was wonderful. It
Thank
was
you, sir.
wonderful knowing your insights. I mean, you have used carbetocin in all these patients, and especially in patients who had a past history of PPH, and
Yes,
there
sir.
did not seem any here. So, it is your experience in short, for past 8-10 months, you have already been using carbetocin. You prefer IV route over IM or?
Sir, I routinely prefer IV route only
IV.
because we consider that we actually put cannula in each and every patient being in private setup.
Yeah, yeah,
We
yeah,
are
yeah,
not
correct.
conducting even the vaginal delivery by without securing an IV line. So we
Absolutely.
prefer IV route rather than IM route. That's why.
And in our science, madam, one line always goes, expect the unexpected. You never know what patient will turn into
Actually,
what.
yeah.
Yeah, actually, it can happen. Very correct. So your overall experience has been good until now using Carbetocin.
Yes, I am actually touch wood very satisfied with the Carbetocin.
God bless. As I said, I saw only one patient of PPH in my lifetime. That was in late 70s in JJ Hospital. My God, it was
Okay.
at that time we
So,
only
sir,
had
it's actually a
oxytocin.
nightmare. We
Yeah,
say that it's supposed to be in discussions in the literature, but you should
yeah,
not
yeah,
have
yeah,
this
yeah.
kind of
We
files
only had
actually.
oxytocin and methargine, and at that time the whole gynecology department of the hospital was in that room. You can understand me.
Yes, sir. That's why I'm saying now we
Yes,
generally know
correct.
one thing that whenever there is PPH, you just crying out for help, help, help.
Absolutely, that's the
Gather
only
as
thing.
many persons
Yes,
as you
yes,
can to
yes,
get
yes.
the help.
Correct, correct. All inputs are necessary. And which patient
Actually,
profile where doctors can anticipate? Any specific patient profile where you can anticipate a PPH?
we can anticipate PPH like sir in grand multipara,
Huh,
in over-distended uterus, like in
correct.
twin pregnancy, or in the case of polyhydramnios, or in case of prolonged labor, or in cases of multiple fibroid uterus, which don't allow the uterus to contract,
Contract.
or sometimes it is a precipitate labor also, which can lead on to PPH. Plus, when there is a previous history of the PPH, it always increases the risk of second time PPH in a patient.
Absolutely. A patient with history of diabetes or hypertension, are they more prone for PPH?
Yes, sir. Whenever there are history of GDM or the essential diabetes
Yes,
or the hypertension,
hypertension.
they further prepone a patient to have a PPH.
When would you actually prefer Carbetocin or Oxytocin? Oxytocin has been our textbook brand, which we have read since ages. And I mean, private setup, there's no question. Straight away, you can use Carbetocin. But in some of the places, government setups, so there are people will still have Oxytocin. So where you would suggest to use Carbetocin over Oxytocin?
So I would say that matlab, now cost is not that major factor because
Absolutely,
whenever we
yes.
get PPH, we spend so much on saving it on the blood. Even in a government setup, we think of we are spending so much on the blood products, on the blood BT sets, each and everything. Overall cost is more when we actually get a PPH. So we always say that it is better to use a costlier drug comparatively. Although carbetocin is
Yeah, yeah.
costly than oxytocin, but the benefit that is providing with the
Expect
single
the best.
dose
Yes.
than anything, that I would say that in every case we should go for carbetocin over oxytocin for the prevention of PPH.
Yes,
Especially when we know that there are no specific dosage protocol for anything. Like for oxytocin, we need to tell our staff, na,
yes,
staff keep
yes,
on
yes.
changing in a government setup. You need to give this, you need to give IV, you need to give IM, you need to give 10 units IM, 10 unit IV bolus. There is a single dose. So if even if the staff is changing, they know, okay, this is the vial, this has to be given, this is how to be given. So it becomes easier in a government setup also.
And operationally, Carbetocin scores because there's a single dose, no IV required. I mean, there are a lot of things.
Actually,
And refrigeration not required because it being heat stable. I mean, in the interiors, we know in cities like Mumbai, we have got power outage. So interiors, we can always expect that stability could be an issue with oxytocin. That's correct.
gradually it's replacing in in our state also when the temperature is so much high and the
Right,
light
right,
are
right.
so much. We actually know
Absolutely.
that oxytocin, even it is put in the refrigerator, na, it's being
May not,
opened so many
yes.
times, and with the light cuts, it's not, the refrigerator is not working properly at all. So
And
we actually needed a heat stable compound. So
right,
I
right,
would say
right.
that it is to be used.
Which we can straight away put in our tray and take the two. So oxytocin will require, I mean, we cannot bring it into hospital straight. Correct.
Actually, yes.
Can we use Carbetocin in cases of retained placenta?
But actually, I would say that I haven't come across any case for the use of carbetocin in case of retained placenta. So, routinely, actually, like if the placenta is retained, we used to give oxytocin followed by misoprostol because it helps in detachment as well as expulsion. But
Yes.
if we think we are using oxytocin, it might help because it is acting on the same receptors
Similar
only,
receptors.
similar
Yes.
receptors. But personally, I haven't get any
Yeah,
experience
correct,
of the
correct.
use of
No.
carbetocin.
Yes, yes, yes. And RH negative mothers here, I mean, the patient bleeds, getting blood is could be an issue.
But I have used carbetocin in three Rh negative mothers.
Oh, lovely,
Uh,
lovely. So
I
this is a good
found it
experience.
is good
I mean,
that thing.
yes, yes, yes. Having a practical experience anytime is always good. And
Since
the recovery was
since actually
uneventful.
Methergine is out in Rh negative patients,
Yeah, 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 yeah.
so we
Sudden
are left
contraction
with
will pull.
very lesser choice and a very rare matlab, blood groups like we are B negative, A negative. Not very much is available in the blood bank
Correct.
also, so we have to be very much cautious, especially in these Rh negative mothers. But I have used in three of my patients, and
Very good.
carbetocin worked wonderful.
Very, very. This is very reassuring. Patient doctors using this is exactly what we want. The doctor's experience in using.
No, I have used
Yes,
in
yes.
all three Rh negative patients.
Can a doctor use carbetocin for prevention of PPH if oxytocin used for induction?
Yes, basically I'm using I already discussed one patient of mine
Yes,
on whom
yes,
I
yes.
planned induction with oxytocin, and for the prevention of PPH, I have completely shifted to carbetocin only. So we can use, because if we were using oxytocin also, it is acting on the similar receptors. So
Correct.
if a patient oxytotocin is used for labor induction, we can comfortably use carbetocin for the prevention of receptors, because we have read in literature that the oxytocin receptors, they matlab, might be desensitized, the oxytocin may not,
Yeah, 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 yeah.
but
Who are
practically we haven't come
doesn't
across
happen.
many more cases like that, so we prefer to use carbetocin.
Yeah. In which cases would you prefer IV? I mean, you people are using IV straight, so no question about that.
Yes.
Otherwise, if a patient is a theoretical question, of course, if a patient is not responding adequately with carbetocin, which could be possible, sometimes it may happen. What
Yes.
additional ureotonics would be used? You would use
Then I would prefer carboprost as the first line.
carboprost. Huh?
Yes. And after that, if the carboprost is also not acting, then I will use methergine if it is not contraindicated in that particular case.
Yeah,
Along,
yeah, yeah.
I may give misoprostol also, because whenever there is PPH, we don't think whatever we are using, we
Yeah, yeah.
try our best to,
We will
along
use
with the
everything possible. Yes,
bimanual
everything.
massage, uterine massage all the time.
Yes, correct. And with oxytocin advantage, I mean, have you seen fluid retention as a side effect with oxytocin?
Yes, fluid retention is a lot when we using oxytocin,
Oxytocin.
especially firstly for the induction, then followed by the for the prevention of the PPH. Then it due to the ADH effects, it sometimes leads to fluid retention.
With carbetocin, no such effect. Of course, a
No
single
such side
dose. Yeah.
effects have been found
Any
with the,
any clot or embolus type of side effect? No.
no side effects I
With
have
okay.
seen till now.
So advantage over oxytocin, we have seen misoprostol.
See, bisoprostol, firstly, it's the prostaglandin. They say that if the patient is not having PPH, right? So we can give it to parvaginum also. But if she is having PPH, then we can't give practically parvaginum,
Correct,
because it's
correct.
not going to stay. And
True,
patient is
yeah.
not in a condition to take it sublingual also. So, and sometimes in asthmatic, we have to think multiple times giving a prostaglandin.
Prostaglandins, yes,
So carbidocin is not to be compared with misoprostol at all, although many studies are there which now say that it is carbidocin is much better than misoprostol.
or even
So,
carboprost.
yes.
And
Now
besides
coming
argument, uh,
carboprost, the prostaglandin itself, that's why
correct.
vomiting diarrhea is a lot. So if the something can be, so carbidocin is far better because it is without any side effects in a post LSCS patient. She is not able to walk, and when she is having diarrhea and vomits, it causes so much difficulty for the patient and so much pain at the stitches now. So actually, it's practically very difficult. So we want to use carboprost as a second line only when actually carbidocin is not working.
Methyl ergometin, of course, the side effect of hypertension is
Hypertension is
yeah.
there, and that's why we can't give in all the cases.
Should carbetocin be kept as a reserve drug or should be used as first line?
So I would say it should be used as a first line. Why to
Yes,
keep
yeah,
strongest
exactly.
force soldier to a backup and killing, getting so much of loss.
Completely agree. Yeah.
Yes.
How would you compare? We have seen efficacy wise they're all similar. How I mean, we have already discussed that side adverse effect. But overall, carbetocin will score over oxytocin. Most importantly, I suppose, in terms of management operationally, no heat state, no refrigeration required, side effects less. When we have discussed this question, your one liner on carbetocin, take home message for the doctors who are attending.
Uh, Single dosage protocol, one time dose, no multiple infusions or no multiple dosages are required, heat stable. So don't worry for the cold chain from the stockist to you and from yours place to the labor room. So I would say it is the first line. It is to be preferred in all the cases.
Thank you, madam, for the lovely insights. I mean, I always say, that having things mentioned in textbooks or references is one thing, and having doctors' experience is another thing. I'm sure all the doctors who have attended this have benefited out of this discussion. Thank you so much, and thank you all the participating doctors who took time from their busy schedule and attended this. Thank you, marketing team Hitro, for conceptualizing. Thank you, field person of Hitro, for taking all the pains to make this happen. Last but not the least, thank you, IT team, for your IT support. Thank you so much. Thanks, all of you. Signing off. Wish you a very pleasant evening. Thank you so much, madam. Thanks once again for the insights.
Thank you, Dr. Prashant, sir. Thank you. Thanks, the Hitro team and the IT team for the backup. And I really enjoyed having this wonderful
It was
discussion
lovely.
because
Yes, yes, yes.
it's lovely to have the knowledge from the company also because they know that what we experience.
Correct. Thank
Thanks a
you.
lot. Okay.
Thanks, Girdhar. Thanks, Priyanka.
Thank you, doctor.
Thank you, ma'am.